Hello, we're back. This is chapter 38, Barbara Garcia for Path 370. So today we're going to talk about the liver. And I want you to remember that the liver is like the most metabolically active organ in your body. And thus it is very susceptible to damage. Okay, so understanding the liver and understanding how the liver gets its blood supply and understanding how the liver is involved in so many processes is really important, and thus this chapter is a little long. Okay, so I'm going to try to break it up into two parts so that it's a little bit more manageable, but I'm going to go through quite swiftly. All right, so it's the largest parenchymal organ of the body, which means, not counting the skin, because the skin is not inside, right? Parenchymal means like made of like structure, right? Altogether. And then it's located in the right upper quadrant of the abdomen under the diaphragm. It is divided into right and left lobe, and then it has a capsule around it, which is very important. And then it's also covered by the visceral peritoneum. And it has suspensory ligaments that we're going to talk about very briefly. If not, you want to go back to the anatomy and look at the anatomy of the liver to see that. There's some really good pictures in the first couple pages of your book. Right, so here you go. These are some of them. So you have the falciform ligament, right? You have the caudate lobes, which are one of the smaller lobes. The quadrate lobe is the other smaller lobe that's probably on the underside of your picture somewhere. The gallbladder is on the underside of your liver, right on the inferior aspect. And then you're going to have the right lobe and the left lobe. Okay, and then you have your inferior vena cava, right? And then here you have a bare area that does not have any ligament. Okay, that has no capsule, excuse me. All right, so there you go. That's a little review on the anatomy of your liver, and you can see right here is your diaphragm. Right, so the liver has a dual blood supply, right? It is both going to be delivered by the hepatic artery. It's about 25%. It's going to come from the celiac trunk. Remember, the celiac trunk has three branches off it, right? It has the the gastric artery, has the splenic artery, and then it has the hepatic artery. So about 25% is arterial, and then the remainder is going to come from the portal vein. And remember, the portal vein, and there's a picture of the portal vein, recollects all of the venous blood from the stomach, the spleen, the pancreas, all of your small intestine, which is kind of excluded from this picture, and your large intestine. So all of the gastric veins, the splenic veins, the inferior mesenteric artery, and superior mesenteric artery, everything that is collected from your intestines through absorption is going to go through the liver before it goes back into the inferior vena cava and enters the systemic circulation. So I want you to understand the importance of that, right? So that portal vein is going to be extremely important. And I want you to understand that the liver functions as kind of like a capillary system. Remember, going back to the anatomy, it has sinusoids and it drops off, right, the blood. This is the venous blood from the portal vein. It drops off the blood at the ends of the hepatic lobules. They go down the sinusoids so that the hepatocytes can function to detoxify, and the Kupffer cells can pick up all of the, any debris, and then as it works its way to the central vein, then everything from the central vein is going to be recollected, right, through and eventually reach the inferior vena cava. Okay, so you see that it is rich in substances absorbed and secreted by the gut. That's why it's really important. So if you start to think about alcoholism and how alcoholism works, I want you to really remember the fact that alcohol hits your stomach, which is a very vascular organ. Alcohol is hydrophobic. Okay, ethanol is hydrophobic. Ethanol is going to cross your membranes. Remember, I call like hydrophobic substances like ghosts, right? They go right through the wall, right through the membrane, right? Other things that are hydrophilic, they have to knock on the door. They have to attach to a receptor. They have to, attach to a receptor or have something attached to a receptor and then open a channel in order to get inside. So they're either going to open a channel to get inside, or they're going to cause a change inside the cell, like a second messenger system. But all of the hydrophobic substances, they go right through the wall. Okay, they're the ghosts. They go right through the wall and into the cell. So your alcohol that you consume goes right through the walls of your stomach and eventually makes its way, right out of the wall into circulation. And so the first thing that alcohol does is that it goes to the liver because it's through the hepatic portal system, right? So that's why your liver is going to be the one organ that's most affected, right, by alcohol. All right, so the afferent blood vessels, right, the portal circulation, I kind of talked about it a little bit, but let's see what it says on the slides here and go one by one, right? Branch into the liver to form portal triads. So remember that at the end of your hepatic lobules, right, there's three structures. There's the hepatic artery, there is the portal vein, and then there's a bile duct, okay? Because remember, the liver also makes bile, right? And so blood from the hepatic artery and portal vein drains into the hepatic sinusoids, where they're surrounded by endothelial cells and Kupffer cells. And then there's, surrounded also by sheets of liver cells or hepatocytes and hepatic plates. The central veins coalesce into the hepatic vein and empty into the inferior vena cava. All right, so you can see there a little bit on how each one of these hepatic lobules appears. And that's basically the entire parenchyma of the liver. The entire structure of the liver is going to be hepatic lobule, hepatic lobule, hepatic lobule, hepatic lobule, like puzzle pieces, right? And so that's exactly how the liver is going to work, right? Right, so obstruction to the flow of blood can lead to something called portal hypertension. And portal hypertension is quite dramatic. And that's probably one of the main things that is going to happen to the liver that's going to destroy the liver. Right? So it also has, obviously, as every organ does, lymphatic drainage system, right? And then 80% of the liver may be destroyed before life is threatened. All right, so as a digestive organ, right, an organ part, as part of the digestive system, it makes bile salts, it makes bile, right, which is secreted for fat digestion. And remember, bile, I was just talking about this yesterday in my physiology class, right? Bile is going to be secreted, and bile is amphiphilic. So bile, amphiphilic, means that it has both a hydrophobic side and a hydrophilic side. And so the hydrophobic side sticks to the little fat droplet we call a micelle, spelled like Michelle but without the H. So the little micelle, or micelle, the little micelle is going to have in it all of the fatty structures, right? So the breakdown of fat. So triglycerides are what we consume. Cholesterol is what we consume, right? So you're going to have the breakdowns. You're going to have monoglycerides. You're going to have glycerol by itself and free fatty acids. Those are all going to be in the micelle. In addition to that, you're going to have your cholesterol in the micelle, and you're going to have your fat-soluble vitamins. The only way your fat-soluble vitamins can get into circulation is through this micelle. And the micelle, like a good hydrophobic structure, can go right through the wall. But it has to be tiny enough. So in order for these fat bubbles to not come back together, they need to have this amphiphilic, that the hydrophilic side can interact with water so that they don't reform. Because you've gotten a vinaigrette where you sit there and you look at the vinegar and the oil separated, and you sit there and you shake it, right? And then they form a bunch of little bubbles. Then you let it sit after you've put it on your salad, and it goes and it whoop, and it coalesces all back into a big fat droplet, which is exactly what would happen in your intestines if you don't have sufficient bile. And thus, when people have gallbladder disease and they don't make enough bile because it's an obstruction, what's going to happen is they're going to get steatorrhea because they have fat in their stool because the fat wasn't broken down into a component that was small enough to be absorbed. So this is how we absorb. And remember, one other thing, the glycerol and the free fatty acids and the monoglycerides are all broken down by lipases. So remember, we make lingual lipase in our mouth and pancreatic lipase from our pancreas. Okay, so it's really important, right, for processing, storage of fats, carbohydrates, and so on. As an endocrine organ, right, it's obviously going to regulate carbohydrate, fat, and protein metabolism, but especially in the form of, glucocorticoids, mineralocorticoids, and sex hormones. So it regulates a lot of the function of these. So for example, it makes angiotensinogen, right? And it makes a bunch of other endocrine hormones. And as a hematologic organ, has a temporary storage of blood because there's a significant amount of blood that goes through the liver, right? It removes bilirubin from the bloodstream. So if the liver is having problem, then bilirubin is going to increase in your bloodstream, bilirubinemia, and you're going to get jaundice. Okay, so hematopoiesis in certain disease states is also going to happen, and you have blood clotting factors that it can also make. So as a hematologic organ, it's also very important. And as an excretory organ, it is going to involve the removal of bile from our system. So it makes bile pigments and cholesterol, and it excretes. It helps promote the excretion of these things, right? And urea. So it also makes urea, and then we detoxify drugs and other foreign substances in the liver, and so then we can remove a lot of these through the bile or urea and or the other urinary or fecal routes. All right, so some of the manifestations of the liver, right? So attributable to hepatocellular failure and portal hypertension. So most diseases are going to be because of that, right? So hepatocellular failure, right, is going to cause, and the liver also makes a lot of makes albumin. So it's like the main source of albumin. So your blood would be low in albumin, hypoalbuminemia. Remember, anytime you see emia, you know it's in the blood, right? It's going to have decreased vitamins D and K, right? So you can lead to osteomalacia, which is low vitamin D. Right, it has poor clotting factor production, which is mediated by vitamin K. And you might have some feminization as well, since it does work with our sex hormones. And again, jaundice is a really important attributable visual sign that there's something wrong with the liver. And jaundice is going to be found in a lot of disorders. A lot of times hepatitis is going to be visible as jaundice, and other, clotting factor disorders is going to be visible as jaundice, and cirrhosis of the liver, if it's really bad, it can also be seen through the visual sign of jaundice. And so portal hypertension. So what is that, right? So there's some sort of blood obstruction that then is causing the blood, right? So as it gets to the liver, to be in higher pressure, yes? So higher pressure in the liver. And so we have GI congestion, right? And then you might have also, as a result, development of esophageal or gastric varices, which are like the veins are going to be affected. So the structure of the veins in the esophagus and or the stomach are going to be affected. You might see hemorrhoids. You might see splenomegaly as a result of, the portal hypertension. Right, and then ascites is also very common, and you've seen all of these in things like right-sided heart failure. Right, so again, hepatocellular failure, jaundice, muscle wasting, ascites, impairment of fat-soluble vitamins because the bile is inhibited, right, and altered lipoprotein processing. One of the other things that the liver does is that the liver is going to convert. Okay, so remember that when you absorb fats into your intestinal cells, we're going to store them as chylomicrons, and the chylomicrons are going to basically work their way to the liver, where the liver is then going to create two types. It's going to create the low density lipoproteins, right, which are going to transport cholesterol to your cells. So it's from the liver to your cells. So you have chylomicrons, which are going to be very, very high in fat content and cholesterol content because they are transporting, freshly absorbed fat into the portal circulation, where then it makes its way to the liver. So the liver is then going to make low density lipoproteins or very low density lipoproteins, and then it's going to convert the chylomicron to very low density lipoproteins, which could be done by intestinal cells as well, but the majority of it is going to be chylomicron. And then low density lipoproteins, which are then going to transport fat and cholesterol and deposit that in your cells, right? So low density lipoproteins are a measure of your bad cholesterol because that means it's being deposited. But the liver also makes high density lipoproteins. But high density lipoproteins, so look at the word lipoprotein, right? So it's fat, right? So phospholipids, and it's going to have protein markers in it, right? Which help it bind and stuff like that, right? So high density lipoproteins, which means of course it has more proteins than it has lipids, you're going to send out as a empty shell and collect cholesterol from your body and bring it back to your liver to become part of the bile and so on and be excreted out of the body. So we want our high density lipoproteins to be high and our low density lipoproteins to be as low as possible. Now, the reality is our low density lipoprotein, depending on our diet, is going to be often higher than high density lipoproteins. But if you had like a 1-to-1 ratio, that would be awesome. If you had a 5-to-1 ratio of low density lipoproteins to high density lipoproteins, it's still okay. Anything higher than that is going to be bad. Those two together, low density lipoproteins and high density lipoproteins, are going to give you basically your quote unquote total cholesterol, right? So your total cholesterol should not exceed 200 on a laboratory, right? Milligrams per deciliter. So somewhere like low density lipoproteins being like 120, and then your high density lipoproteins being at least 50, possibly but more like 60, are probably good numbers, because that number would still be 180, which is less than 200, and you're still fairly good. The lower the number, of course, the better. Okay, so sorry, just thought I'd throw that in there because some people don't remember how that's made. So altered lipoprotein processing is going to result in dyslipidemias, particularly in hypertriglyceridemia, right? So high levels of triglycerides, so not being transported properly. All right, then abnormal storage and release of glucose in the form of glycogen, right? So remember, okay, now another thing, right? The liver is the only organ in the body that can turn glycogen, break it apart during the fasting state when we're not eating, break it apart into individual glucose 6-phosphates, which that's what we make glycogen with, glucose 6-phosphate. And when glucose enters the cell, it gets phosphorylated by hexokinase or glucokinase, depending on the cell. Then you're going to form, in high insulin states, you'll form glycogen. Then glycogen in your fasting state, right? In your low, when you're not eating, glucagon is going to come and break down the glycogen, right? It's going to do glycogenolysis. Then we form glucose 6-phosphate. Glucose 6-phosphate in every other cell, in your muscle cells and your fat cells, are stuck inside the cell, only to be used for making ATP within that cell. Then it would enter glycolysis and go to the Krebs cycle. However, in the liver, we have an enzyme called glucose 6-phosphatase that can actually take the phosphate group off and make glucose and deliver the glucose to your blood circulation. So your liver can contribute to your glucose levels in your blood. So you can have hyperglycemia, right? Or if it doesn't function, then you have hypoglycemia. So it's really important for you to understand that as well, right? And then obviously inadequate protein metabolism. So you're going to see decreased production of clotting factors. So you can have excessive bleeding and hypoalbuminemia, which is going to lead to generalized edema related to low serum oncotic pressure. So I kind of covered that over in one of our previous chapters, but remember that you have this thing called colloid osmotic or oncotic pressure. It's the same thing. Colloid osmotic pressure is the pressure that is driven by osmosis. So osmosis goes from an area of high concentration of water to low concentration of water. And that movement is from your tissue, which is low in proteins, because proteins are very high in the blood. So osmosis wants to go from your tissue to your blood. But normal delivery of nutrients involves the arteries and blood pressure, which is a hydrostatic pressure that pushes stuff out. So if you had, for example, hypertension, so you have a lot of pressure, so your hydrostatic pressure is high, and you also had hypoalbuminemia, which means that your osmotic pressure is low, then all of it's going to be pushing nutrients out and delivering blood and water with nutrients out of the cell. And so that causes edema because of the low osmotic pressure. I mean, and then you're adding the high hydrostatic pressure from your blood pressure, right? So go back and review that if that isn't something that you're comfortable with. Okay, so delivery of nutrients to the capillaries back in the cardiovascular system. All right, so then impaired processing of endogenous steroid hormones, right? Estrogen. So estrogen is made in high quantities in our liver, not super high, but higher than not like your ovaries, but in men, right? So that steroid hormone would be in excess, right? And it could lead to gynecomastia, impotence, testicular atrophy, and more of a female hair distribution. In women, it could lead to irregular menses, right? Palmar erythema, right? Erythema, and spider telangiectasias, right? Which are kind of abnormal clusters of capillaries. And then palmar on the palms of the hands, right? So impaired clearance of exogenous drugs and toxins. So much like the kidney, right? So they've always told you that your drugs are going to get processed by one of two places. It's either going to be the liver or it's going to be the kidneys. So, we always have this like, well, what pain medication do you want to take? Do you want to take Tylenol? Cool. But don't take too much Tylenol because it could give you cirrhosis of the liver. No joke. Or you can take aspirin. Oh, but aspirin can affect your kidneys. Okay, so it depends on which one, right? So those are our two main areas that are going to detoxify our drugs. It's either going to be your liver, right, or your kidneys. And then, of course, it helps convert ammonia to urea. Okay, so ammonia is toxic. So we have to process ammonia into a less toxic form, which is the urea. And so the urea then can get eliminated out of our body. Right, so jaundice, right? A major characteristic sign, right? Sign because it's visible. Now, in people with darker skin, I want you to go to the sclera of the eye to see really that manifestation, right? The sclera of the eye, the white part of your eye, is going to be very yellow in people with jaundice, but especially if you can't see really their skin because they're dark in color, right? So it's a greenish yellow staining of tissues by bilirubin, right? And it results from impaired bilirubin metabolism, right? So damaged red blood cells, right, release hemoglobin B, and heme and globin separate. Heme releases the iron that is in the center of it, and biliverdin, right, which is now your heme basically without the iron. So the biliverdin is acted on by bilirubin reductase to bilirubin, and then bilirubin is this unconjugated lipid soluble released into the plasma and then transported to the liver by albumin. Okay, so then these special transport proteins in the liver extract the unconjugated bilirubin from the plasma, and then the bilirubin is bound, so now it's conjugated. So a lot of times if you have jaundice, they'll find out whether the bilirubin is conjugated or unconjugated, find out where the problem is, right? And then 2, glucuronic acid by uridine diphosphatase, glucuronal cell transferase, sorry, that's a big word, a big enzyme name. And then it yields the water-soluble bilirubin that's excreted into the bile ducts, right? So it's transported as bilirubin as a component of bile is transported into the small intestine. It passes to the colon to be broken down into urobilinogen and passed in the feces, right? A fraction of it is reabsorbed back into circulation and to be excreted in the kidneys. So both of those are going to actually contribute to the color that you're going to see in in your fecal matter. So your fecal matter is going to be like brownish in color, and then your urine is going to be yellowish in color. So that's going to be from the processing of bilirubin, right? So jaundice results from dysfunction anywhere along that pathway. Again, they might find out whether your bilirubin is unconjugated or conjugated to find out where the problem is. Right, so you can see there's a little bit of a review on how that works in a nice little chart. This one is also going to be found in your book on an entire page on 758. It's figure 38-4. All right. Then what are the prehepatic causes of jaundice? So hemolysis, ineffective erythropoiesis, or reabsorption of large hematomas. So some of those can lead to jaundice, right? Some hepatic causes are dysfunction of the liver cells, right? Increased levels of conjugated bilirubin, right? Immature, the enzyme UDPGT, physiologic newborn jaundice, could be from UDPGT mutations. Post-hepatic, right, at the level of your bilirubin transport, or, conjugated hyperbilirubinemia, and then mechanical obstruction of the bile ducts. So those are some of the different causes of jaundice. So evaluation, so complete history and physical exam, looking for telangiectasias, ascites, palmar erythemias, gynecomastia in males, right, which is enlargement of the breast tissue in male, testicular atrophy, hair loss in men, central obesity with peripheral muscle wasting, underlying causes alcoholic liver disease, right, drug reactions, metastatic or primary malignancy. And so some of the diagnostic tests are going to include biochemical assays that are going to tell us a little bit about what's going on in terms of the enzymes and so on. Needle biopsy of the liver that can tell us what the cells are and how they're working. An ultrasound of the liver can tell us visually what's going on if there's an obstruction. Right, a CT can do pretty much the same thing, but ultrasound is less visible, and a CT is very, very, very good. ERCP, which is endoscopic retrograde cholangiopancreatography, which is going to be a procedure that they could do to see if the liver, bile ducts, or the pancreas has any disease in it. And then the MRCP is the same thing, but it uses magnetic resonance. So it uses like an MRI type machine to do the same thing. Right. And then some other laboratory tests, right, that they could do is to see if there's any hepatocellular disorder like hepatitis. Any type of hepatitis is going to have a elevation in the transaminases that are out of proportion with other liver enzymes. Alcoholic or toxic hepatides are going to be elevated AST over ALT. And then any intrahepatic cholestasis, like indicating more carcinoma or sarcoidosis, are elevated ALP. So all of these are different enzymes that your liver makes, right? So these are called the liver enzymes, right? So, right, hemolysis is going to be elevated unconjugated hyperbilirubinemia, and then any extrahepatic cholestasis is related to biliary obstruction, and you'll see elevated conjugated bilirubin, and then cirrhosis is elevated in basically all the parameters. Right, so portal hypertension, again, sluggish blood flow resulting in increased pressure in the portal circulation. And then this causes a congested venous drainage of the GI tract. Okay, so portal hypertension causes a backflow problem, yes? So the GI tract is not going to be able to deliver its blood efficiently and effectively to the liver. So some manifestations include anorexia, and you have esophageal, gastric, and even hemorrhoidal varices, which can rupture, causing some uncontrolled bleeding, and ascites, which is accumulation of fluid, right, in the abdomen, in the peritoneal fluid. Right, so gastroesophageal varices usually result from portal hypertension, very commonly in alcoholic or post-hepatic cirrhosis, or it could be from infection of liver flukes, which is not common in this country, but it is common in other countries, which have, liver flukes, and usually third world countries. Vasoactive hormones, right? And then increased splenic blood flow and increased vascular resistance in the liver. So all of those can cause gastroesophageal varices. Right, so pathogenesis of these varices, right? So the venous network surrounding the proximal part of the stomach and esophagus can rupture with when it's critically high pressure, leading to massive, life-threatening upper GI bleed. And collateral venous pathways dilate in response to elevated portal pressure. So basically, in an attempt to transport blood from the splenic bed, right, around the cirrhotic liver and back to the heart. So you can see here some of the, right, gastroesophageal venous circulation. So you have the gastric zone, right, around here. And then these are the varices that are going to be surrounding the upper stomach and the lower esophagus. So then you can have a varix, right? And so you have multiple varices that then can obstruct the flow even of food down the esophagus. Right, so some of the clinical features affects about half of patients with cirrhosis. Right, the size is the main determinant for bleeding. So you might have variceal bleeding, and the mortality of variceal bleeding is up to 50%. Right, so two distinct phases of variceal hemorrhage, right, coincident with and shortly after bleeding, or a period of 6 to 8 weeks after bleeding. So greatest risk of rebleed occurs in 72 hours. So some of the manifestations are hematemesis, which means you're throwing up blood, right? Melena, which means it's in the stool, like very kind of brownish, tarry stools, right? Bright colored rectal bleeding, that's for more hemorrhoidal, anemia and shock, right? So then fluid resuscitation is normal, right? Via saline and via a large bore IV, so that's going to help replenish the fluid that's lost, right? Correcting any coagulopathy problems and any further bleeding problems with blood products, especially things with clotting factors. So vitamin K, right? Fresh frozen plasma, platelets, and recombinant factors 7. Right, so some of the other treatments include vasopressin, right? So vasopressin, remember, is antidiuretic hormone, so it's going to reabsorb more water. Nitroglycerin, remember, nitroglycerin is a vasodilator, so it dilates your blood vessels. So some people take nitroglycerin for angina, right? So they take it right underneath, like sublingually, and so nitroglycerin can help lower even portal hypertension, right? Octreotide acetate used to replace vasopressin, metoclopridine, right? Histamine blocker, proton pump inhibitors, beta blockers, and antibiotic therapy for any of those gastroesophageal varices. Right, you emergency, right, esophagogastroduodenoscopy, right, so that we get a good view of what's going on down in there, right? So especially, right, some sclerosing substances being delivered around the varix so that it can result in hemostasis, right? So, and thrombosis. You can see there's some endoscopic sclerosis, so that's kind of helping that varix. And then there's some other ones in your book if you want to see them, the procedure on figure 38.8. Right, so endoscopic ligation of esophageal varices, right? You suction and then ligate the varix, right? Endoscopic, techniques show mortality benefit compared to just medication. So you can see there that process of endoscopic ligation, right? Also can be a balloon tamponade of varices, right? Was widely used before endoscopic treatment with a gastric tube. That's the Sengstatten-Blakemore tube, inflated and held against the varix and the fundus. And then, so it helps with compression hemostasis and occlusion of blood flow. So you can see that one there with the gastric balloon. and the esophageal balloon that then helps the stasis of blood. Right, so then other treatments include transjugular, intrahepatic, portal systemic shunts, sometimes liver transplants, esophageal transection, and reanastomoses, right? So basically making other collateral channels, or ligating other collateral channels so that they don't get more blood flow, right? Portocaval, mesocaval, or splenorenal and distal splenorenal shunts. So you can see some of those different techniques right here in shunting, right? So hepatic encephalopathy, right? So pathogenesis, right, is a complex neuropsychiatric syndrome from too much ammonia, right? So you're going to see associated with hepatic failure or severe chronic disease. Exact cause of this is unknown, but is precipitated by certain conditions that increase protein metabolism. So GI hemorrhage and increased protein consumption by conditions that further impair hepatocyte function. So this is hepatic encephalopathy. So some of the manifestations are dementia, psychotic syndrome, spastic myelopathy, cerebellar or extrapyramidal signs. You might have asterixis or a liver flap, which is a characteristic classic sign of hepatic encephalopathy. So spastic jerking of hands when they are held in forced extension, right? And then ammonia levels are going to be very high, so they correlate positively with the level of encephalopathy. So you have malconfusion to lethargy, and malconfusion and lethargy to stupor and coma. So that's grade 1 through 4. So treatment is basically getting any of those precipitating factors and correcting it and restricting dietary protein. Right, so making sure that they're receiving at least 400 grams of carbohydrates daily. And then maybe reintroduced with dropping ammonia levels, right? So reintroducing dietary protein to about 20 grams per day, increasing by 10 to 20 grams per day for a few days, to the highest of 0.75 to 1 grams per kilogram of body weight daily. All right, so then treatment, right? You're going to get some peripheral or central IV infusions with vitamins, high fiber diet, right? Because that means that you're not going to be making any of those, or not transporting any of those vitamins efficiently, a high fiber diet to replace the protein from the diet, right? And amoxicillin and rifamycin, right, to suppress some of the intestinal flora that break down dietary protein and release ammonia, and lactulose, which is dose titrated, too soft, and acidic stools per day. So that's what we're looking for, right? So elimination of nitrogenous waste. And then cerebral edema. So pathogenesis includes swelling of the brain, right, causing decreased brain perfusion, and is the major cause of death with acute hepatic failure, right? So some of the clinical manifestations of cerebral edema include deepening coma, systolic hypertension, rigidity in the extensors. So we call that the decerebrate posture. You might want to look that up. And pupillary dilation and respiratory arrest, usually when the herniation in the brainstem is occurring, right? So we infuse, IV infuse mannitol, which increases the serum osmolarity and draws water from the brain to reduce the swelling, right? So sodium pentothal if mannitol is not tolerated, and placing the patient in a semi-Fowler position to also moderate any hypothermia, and survival is about 60% with aggressive treatment of cerebral edema, right? So ascites is a pathological accumulation of fluid in the peritoneal cavity, right? Also occurs with portal hypertension, and hypoalbuminemia occurs with many other conditions like right-sided heart failure, right? So diagnosis, right? Fluid examination of the abdominal via paracentesis. So looking at the total protein and albumin, that helps us figure out, right, the ascites treatment, right, which is then going to be sodium restriction to 88 milliequivalents per day. Bed rest, diuretics, again, paracentesis, which means removing the fluid, And you might see a Levine or Denver shunt, and some also of the tips, and liver transplant if necessary. Okay, so you can see here the Levine shunt to take the extra. Basically, we're just kind of almost following the lymphatic pathway and taking the shunt to remove the extra fluid from the abdomen and placing it back in the circulation. Right, so a patient has ascites. Which intervention is priority? Right, so administer mannitol, restrict sodium. So B, restrict sodium. C, insert a Sengstatin Blakemore tube. Or D, monitor surface antigen levels. Okay, so ascites. Right, remember the mannitol was for cerebral edema, and the Stenstatin Blakemore tube was for esophageal varices. So we can eliminate A and C. Now, we were just talking about it, so you know that the answer is restrict sodium. So let's find out what usually they want from the surface antigen levels, which I have a feeling are going to be due to hepatitis. Okay, so spontaneous bacterial peritonitis, right? So that is a bacterial infection in the peritoneal cavity, usually of gut origin. So it's some sort of infecting organism of gut origin. So cirrhosis and ascites are your major risk factors, right? And then they diminish the reticuloendothelial function, and then basically transmigration of gut bacteria along the intestinal wall into the ascites that's already in the abdomen, right? So that is going to cause some mild abdominal discomfort, but general clinical deterioration, worsening hepatic encephalopathy. You might see renal failure, a nonspecific septic-like picture, and significant fever may be lacking. So you might see some septic-like signs and symptoms. So diagnosis of paracentesis to find out the leukocyte count, and then plus a culture of the abdominal parasympathetic fluid, right? Then antimicrobial therapy, right, with the third generation cephalosporins or quinolones. This bacterial peritonitis has a very poor prognosis. Hepatorenal syndrome, right, is acute progressive disease, which has normal kidney with disturbed intrarenal blood flow. So there is a basically relating to an imbalance between vasoconstricting and vasodilating mechanisms. So you'll see a rising serum creatinine levels and oliguria. Okay, so these, remember, the treatment, there's a poor prognosis, so we have to have preventive and supportive treatment. Hemodialysis may be necessary, and maybe even a liver transplant. So other disorders of the liver include hepatitis, right? So hepatitis can lead to inflammation of the liver, parenchyma, and can be caused by many viruses, including cytomegalovirus, Epstein-Barr virus, and your viral hepatitis can be hepatitis A, B, C, D, or E, right? So hepatitis A is an RNA virus spread by the fecal-oral route, right? Also called enteric hepatitis. It has a 2 to 7 week incubation period. Remember, so this is fecal-oral route. So it could be that somebody might be, might have it and spread it through food. Okay, so very commonly, basically seen through, they didn't wash their hands properly. That's basically what that is, right? So through food contact, right? So followed by jaundice, lasting approximately 2 weeks, and a self-limited course. And so you might have, the prodromal period, right upper quadrant pain, malaise, anorexia, nausea, low-grade fever. Children may not experience jaundice, right? So some serological testing, you might have anti-HAV IgG, which means it's a previous infection, and if there's IgM, it means there's an acute infection, right? So it's going to be really important for us to start distinguishing between IgG and IgM, okay? So I don't know if you remember, right, but IgGs and IgMs are going to be made at different points of an infection, right? So if it's a first primary infection, you're going to have IgM be very, very high. IgGs are going to come in at a little bit later after the plasma cell, which is your B cell, has already been primed to make it. So in a first infection, IgMs are going to be high. IgMs are going to be high in the first infection because it's the first time you've been infected, and then IgGs come in afterwards, so maybe like a week or so after. But in the secondary infection, IgGs are going to be high. So IgGs are high after the first week, right? And then they're going to be high any other time you might get the infection, because IgGs mean that we were already exposed to this and we could deal with this. We were already exposed. Okay, so treatment is supportive, right? Avoiding ethanol, acetaminophen, and hepatotoxins, so anything that can affect the liver, right? Careful, right, with careful hand washing, segregation, cleaning of laundry and personal items, immunization, and the gamma globulin. So that can increase, right, the ability for the body to get rid of the virus. Partially double-stranded DNA is our hepatitis B virus, right? This one is going to be spread by parenteral contact with infected blood or blood products. So hepatitis B, right, which is, we receive, especially healthcare workers are going to receive a vaccine for hepatitis B, because hepatitis B is going to, most people with hepatitis B are going to lead to chronic infection. So they're going to have that infection for life. Whereas hepatitis A was self-limiting, right? And so, so most of the time it's going to be contaminated needles and sexual contact, right? And then hepatitis B is going to be spread a lot in like the injection drug user population. So that's why one of the reasons, not just HIV, but one of the other reasons that is going to make you, right, want to even exchange needle programs to have those programs available so that we can limit the infection of people with hepatitis B. Right, also called serum hepatitis, because remember, it's basically more in the blood. It's passed through the blood, right? So then 300 million people of the world have chronic infection. About 5% of the world population has chronic infection with hepatitis B. So about 1 to 1.25 million in the United States, right? So some of the risk factors, right? Perinatal or healthcare settings. This is why all nurses need to be vaccinated against hepatitis B. Transfusion and dialysis, right? Acupuncture, tattooing, extended overseas travel, and residence in an institution, right? Incubation period anywhere between 2 to 6 months. The prodromal period may have maybe asymptomatic, have rashes, arthralgias, arthritis, angioedema. You might see serum sickness, glomerulonephritis, or jaundice lasting 2 weeks or so, right? So serologic testing, a little bit more complicated, but this is what we just saw, right? So surface antigen, right? The surface antigen, which the HBsAg, that means the surface antigen, indicates an earlier active chronic infection. Remember, that is the antigen that's in the virus. Surface antibody means that we already have a plasma cell, right? A B cell that was transported into a plasma cell that is now making antibody to protect you against this. So that means resolution and immunity. The core antigen, which is the HBcAg, right, appears first in active infection, right? And then core antibody HBcAb is going to be in seroconversion. And then hepatitis B E antigen, it also means viral replication and infectivity. So in people who were exposed, right, and have immunity, they're going to have the HBsAb antibody. People who were vaccinated will have the core antibody. I believe. I could be, let me check on that, but pretty sure that's it. All right, and then persons with detectable virus, right, which means that they're positive, right? They're positive with HBeAg, can transmit the virus to their contacts and should be counseled, right? Supported, right? Most non-fulminant infections resolve spontaneously. About 5% progress to chronic infection. Most are going to need probably a liver transplant, right? So interferon alpha is a treatment, right? 24 to 48 weeks of therapy. The response rate is 33%. Lamivudine, telvudine, defovir and tenofovir, and entecavir are antivirals of choice, right? So those 5. And then the entecavir being the treatment of choice with a response rate of about 67%, but it is extremely expensive. Right, so immunizations, right? We give doses at 0, 1, and 6 months with a 95% response rate. So it's recommended as part of the childhood vaccination regimen, especially for people at high risk, right? So like if your parents have hepatitis B or somebody in the family has hepatitis B, and after exposure, right? So administration of HBIG after post-inoculation, right? So you might see containing, so it's prevention. Administration, right, is going to have high levels of hepatitis B surface antibody. So if you have surface antibody, means that you were just, right, infected. So given within 7 days of exposure. So for example, in neonates born to mothers who are positive, the HBsAg, remember that means that they have the antigen, right? That are people who are born to mothers who are positive, so neonates. Prophylaxis after a needle stick or sexual exposure in non-immune persons. So if they test you and you do not have the antibodies, and if you have been stuck with somebody who does have hepatitis B surface antibody, and then after liver transplantation in patients who are HBsAg positive prior to transplantation. Right, so then hepatitis C, right, single-stranded RNA virus. It is a type of flavivirus. It is spread through IV drug use or blood transfusions prior to 1990. You might also hear it called non-A, non-B hepatitis. About 3% of the world is infected. There's 6 types. Type 1 is the most common in the United States, but has a lower response rate to treatment. Types 2 and 3, common to North America, and types 4 to 6 are common overseas. Right? Basically, acute hepatitis C infection is asymptomatic. The course is erratic. You can see wide fluctuations in liver enzymes. Right? So it's usually asymptomatic until advanced liver disease intervenes. Most common case of end-stage liver disease with cirrhosis. That's why, I don't know if you've seen some commercials where they are kind of encouraging people to get hepatitis C, check if they have hepatitis C, because it is asymptomatic and it could lead to things later on in life. So, and then they have new medications that are useful for treating hepatitis C. Right, so supportive and expectant, right, and early treatment is not recommended because only 20 to 40% of acute seropositive patients will convert to seronegativity at an undetectable level during the first 6 months after infection. So immune globulin is not helpful in preventing infection. Right, so treatment for chronic infection, right, is assessed by viral load and viral genotype. Liver biopsy to basically check the stage disease, right, and then pegylated interferon alpha with ribavirin and protease inhibitor, right, is 5 to 10% dropout of treatment because of the side effects, quite costly as well. And in type 1 is 48 weeks, other types 24 weeks. Right, so treatment for chronic active hepatitis C infection is to vaccinate against Hep A and B, right, also counsel against blood-borne precautions. And then the Centers for Disease Control and Prevention does not currently recommend barrier methods for patients with long-term sexual partners because of the apparent low risk of infection. If you want to know more about some of the more recent advances in Hep C treatment, you could go onto the hepc.liverfoundation.org, and it has all of the new medications that have been FDA approved to treat hepatitis C. And basically they're like once daily pills that either are single or combination pills with different antivirals in it. So I think the one that I've seen most in the commercials is probably Harvoni, which is the Ledipavir and Sofosbuvir, and that one is basically a combination once daily combination pill. So that actually gives a lot of hope to people with hepatitis C infection. All right, so then hepatitis D, right, is a defective RNA virus that actually requires the helper function of the HBV virus to replicate. So if you get HBV, then you're at higher risk to get hepatitis D, right? So, and it appears to accelerate and worsen the HBV infection. Again, it's transmitted parentally and through intimate contact, with especially, with people that already are HBV infected, right? So prevention of HBV infection also prevents HDV infection, right? So you're going to have the anti-HDV IgM and IgG enzyme-linked immunosorbent assay. Remember, those enzyme-linked immunosorbent assays are called ELISAs. There's no specific treatment for this, but just prevention, right? Safe sex practices, avoiding IV drug use, and vaccination of susceptible persons with the HBV vaccine. So if we stop HBV, then obviously HDV can't get anywhere, right? So then hepatitis E or HEV. So Hep E is an RNA virus that's spread through the fecal-oral route, mostly in contaminated water, right? Or parenteral transmission. So most common in developing countries, or recent travel to those countries. Is a relatively high mortality rate in pregnant women, and the incubation period is about 2 to 9 weeks. Right, so you might see prodromal and icteric illness, right? So in the eyes, usually lasting only about 2 weeks, similar to HAV infection, right? And then supportive treatment and prevention is careful hand washing, avoiding of undercooked foods, and drinking safe water and beverages in other countries, right? So that it doesn't lead to things like chronic hepatitis. So chronic hepatitis is a group of diseases characterized by inflammation of the liver that lasts 6 months or longer, right? So it could be autoimmune diseases, right? Viral hepatitis for B and C, right? Toxins, metabolic diseases, right? So those are things that can cause chronic hepatitis. So chronic persistent hepatitis is a chronic low-grade fever, right, seen which is inflammation of any cause, also called triditis or transaminitis, right? And then inflammation confined to portal triads without destruction of normal liver structures. Some of the clinical manifestations include asymptomatic or mild non-specific symptoms. The treatment is has no drug treatment and is excellent in its prognosis. Chronic active hepatitis is a progressive and destructive inflammatory disease of the liver lasting greater than 6 months, extending beyond the portal triads to the hepatic lobule, right? So we call it piecemeal necrosis. So it's going to go, piece by piece necrosing, right? And it can progress to cirrhosis. So some of the clinical manifestations of this disorder is fatigue, malaise, nausea, anorexia, ascites, hepatomegaly, abdominal pain, and jaundice. So basically, looking in the laboratory values for abnormal liver enzymes and serological studies that can indicate some type of HBV or HCV infection in a liver biopsy can confirm the diagnosis and give you the grading and staging of the disorder. So that's all the diagnostic tests, right, and treatment depending on the cause. You have autoimmune hepatitis. So some autoantibodies, which means antibodies made against our own tissues, right? So, for example, positive ANA as a high level. Also, some anti-smooth muscle antibodies can be possible, right? So, corticosteroids, right, to lower our immune system are going to be used. And then cyclosporine for non-responders, so basically like chemotherapy, right? Immunosuppressive drugs like azathioprine. Right, so I'm going to stop here, and then I'm going to come back with the second half, starting with cirrhosis.